Thank
Very
you.
good. Thank you, Dr. Bradford. All right. So the title of the presentation, as you can see, is Witchcraft, Harnessing the Spooky Power of Placebo. Of course, this is in reference to our own our own experience with our own chairman's skepticism occasionally from unusual phenomena and placebo responses in the clinic. So what is the placebo effect or response? Well, the history of the word placebo is actually quite interesting. So it originates from Psalm 116, chapter 116, verse 9. Placebo domino in regione vivorum. I will walk with, or I will please the Lord in the realm of the living. And this lyric, if you will, was sung in medieval France as part of the funerary rites. And so people who would be interested in getting in on the funerary feast, but who were perhaps unrelated to the deceased, would work their way in by joining and singing, beginning with this line. So the word placebo came into the English language from French and came to mean a sycophant or parasite, one who deceives in order to gain some sort of advantage or favor. Now, the medical use with which we are all familiar now and has really supplanted the prior definition really comes from Professor William Cullen of Edinburgh, who was a very prominent figure and physician in the Scottish Enlightenment, and in fact was the personal physician of David Hume, as well as mentor to Dr. Benjamin Rush, one of our founding fathers and the only physician to sign the Declaration of Independence. So William Cullen, wrote that about a single case regarding a certain patient. I considered him absolutely incurable, and as hastening very fast to his fate, I took him in hopes of making some observant upon his case, and even of learning something by his death. I prescribed, therefore, in pure placebo, but I make it a rule in employing placebos to give what would have a tendency to be of use to the patient. So in this line, we can already see several concepts which were standard at the time and commonly applied, but which became kind of standard for what a placebo is in clinical setting and how it's used. So within a few years of this recorded use of the word, we have that it was firmly established in the medical jargon and widely circulated. Now, the linking of placebo as a form of control in a clinical trial to this widespread and long-standing use of inert or harmless or useless medications to placate or please the patient, and placebo obviously means I please in Latin, forgot to mention that, has really came a bit later. So the use of blinding in clinical trials has its origin really in medieval church practices of using fake relics in exorcisms to assess if the victims of the possession were truly possessed or in fact were faking it, so to speak. We also have in early medical evaluations of Franz Mesmer's techniques, which by the way were pioneered, the trials of Mesmer's work were pioneered by Benjamin Franklin when he visited France, and other kind of trendy medical technologies like Perkins tractors, which were these magnetized rods that were supposed to draw out bad humors. We see the use of these blinded trials throughout the 17 and 1800s. The most modern, the first really recording of the modern application of the placebo control, as we know it today, was done by a physician, Austin Flint, in an effort really to prevent dropout in what was at the time a trial of various remedies for rheumatoid arthritis. And he prescribed a very dilute tincture of cinnamon and saw that the patients that received this treatment did not fare any worse than the patients who received the standard best treatment for articular rheumatism at the time. And in fact, this treatment of dilute tincture of cinnamon became known as the placeboic treatment for articular rheumatism and became widely applied. And it was well known that this was a form of placebo. Now, in the early 1900s, as modern biomedicine and randomized clinical trials began to take off and form sort of the processes, statistical methods, and techniques which would be the basis of evaluating clinical evidence as we know today, the early researchers were struck by the extent to which the control group would improve. And this was actually a very puzzling and disturbing phenomenon to many of these researchers. And often they would, chalk this up to suggestion or psychic effects, or essentially the sort of convincing and what we think of sort of the psychological benefits of placebo today. It wasn't until the 1930s when the term placebo control was explicitly named and formalized as a method in randomized clinical trials. And it was actually at Weill Cornell, well, now known as Weill Cornell, at the time known as Cornell, in 1946, at the Cornell Conferences on Therapy, a major watershed moment really in clinical research, where Dr. Harry Gold became an instrumental figure in standardizing and formalizing the use of placebos as clinical controls. He was a pharmacologist and someone who went on to pioneer a lot of interesting research in the placebo effect and the placebo response. He formulated several classifications of placebo, including what he called pure placebos, which, as we come to think of it, are inert pills like lactose or saline injections. Impure placebos, by which he meant drugs that were given at lower doses than would have a standard therapeutic effect. And he was really the first person to describe the placebo effect as such, as the placebo element. This was distinct from what we know today as the placebo response in a clinical trial. So here we need to make an important distinction in definitions between the placebo effect and the placebo response. So what is the placebo response? Well, the placebo response is the sum total of measured change in the placebo group in a randomized clinical trial. It could also apply it to the clinical setting, but that isn't the typical definition. It represents an aggregate phenomenon, so it includes statistical effects, it includes things like regression to the mean, and we'll discuss later in this presentation the components of the placebo response. But one of its components is the placebo effect. Now, the placebo effect is going to be the main focus of this presentation. And the placebo effect is the psychophysiological response to this, symbolic inert treatment. It is a very individual and contextual phenomenon. It represents the specific action of the placebo intervention. And it can be specifically therapeutic if the effects of the placebo are negative, that is, if the patient experiences side effects, this is termed the nocebo effect. That is, instead of placebo, I shall please, nocebo means I shall harm. So we'll keep these definitions in mind as we go forward. So at the middle of the 1900s, we see a distinction in what that oftentimes remains in people's minds today, a distinction between the historical clinical use of the placebo and the use of the placebo control in randomized clinical trials. And the differences in these definitions and kind of models of the placebo are most evident in two papers published within a year of each other. One called The Humble Humbug, which was published anonymously, actually, in The Lancet in 1954. And it kind of highlights sort of the prevailing stereotypes about the placebo effect and the clinical use of placebos. It is something that a doctor may use in desperation to ease their own burden in treating a patient in whom they have lost hope, in whom they cannot think of anything else to do. And perhaps a patient also that's somewhat inadequate, or somehow, we have all these stereotypes of patients who are complaining a lot more than we see clinical or physiological evidence of disease. Or patients who are actively dying, for whom there is not much to do, and for whom modern medicine is powerless. And so in order to instill confidence and treat ourselves as much as we treat the patient, perhaps we give some symbolic treatment which perhaps would inspire hope or ease their suffering. Additionally, it's come to, not in this paper, but later works, would criticize the widespread use of placebos as a major violation of the emerging principles of autonomy and informed consent, which again were being formulated and sort of expanding in the 1950s and 60s, a time when medicine was transitioning from a very paternalistic model to something that we more easily recognize today. In fact, this brings us to the next sort of the countervailing view of the placebo effect, that of the randomized trial researcher who was dealing with a phenomenon that was a major threat to their work, an intervention which was highly effective subjectively, produced amazing results, could mimic almost any medication, and required strict blinding and control to rule out. It could produce beneficial effects, it could produce toxic effects of the patient. And the summary of this placebo phenomenon was written up by Dr. Henry Knowles Beecher in 1955 in a paper titled The Powerful Placebo, one of the earliest and most well-cited papers on the subject. Dr. Beecher was an interesting guy. He, in the 1950s, performed some sort of truth serum LSD experiments on college students for the US military, and then kind of turned away from that and became a major advocate for ethical, informed consent in clinical trials. He first became interested in placebo research when he noticed that soldiers on the battlefield required significantly less morphine than civilians who had similar injuries. And he began to be interested in sort of the contextual environment patients experience their suffering and what effect that has on pain specifically. So dealing with these two different notions of what the placebo is, and really a lot of the modern trials since the 1950s have been focused on the placebo effect within randomized clinical trials. And it's really a phenomenon that arose out of that to be studied scientifically. Again, previously the placebo was kind of like a dirty little secret inside medicine. Maybe I exaggerate a little bit, but it certainly did not have the interest of major researchers and scientific inquiry. So let's look at the placebo effect from a modern perspective, starting with randomized clinical trials. So one of the largest meta-analyses in the Cochrane Review of clinical trials with a non-treatment arm, that is to say a verum treatment, a placebo treatment, and a no treatment intervention arm, allows us to look at some of the general effects of the placebo response. So for instance, we're able to tell that certain kinds of placebo interventions will give you a greater response. For instance, a pill placebo, that is what we normally think of as, a lactose-containing inert pill, will give you, standard mean difference in trials of roughly, 15%. And this can vary a lot, anywhere between 0.3 to a lot less, to almost no differences. In this meta-analysis, they were able to find trials with what they called psychological placebos, that is undirected clinical interviewing, certain control psychotherapy type interventions, and even control biofeedback interventions. And they noticed that those have a greater placebo response. And finally, physical placebo interventions, such as acupuncture, placebo acupuncture, such as placebo devices that are hooked up and not turned on, and placebo surgery, which we'll discuss in the next slide, have the greatest placebo response in clinical trials. We also see that subjective measurements of placebo response are most likely to be affected by the placebo. So patients that are reporting their own pain, their own quality of life, things like fatigue, that rely on patient descriptions and evaluations of themselves are subject to a much stronger placebo response in a clinical trial. Whereas objective measurements done by clinical researchers or objective scoring by a third party, or even measured variables, physiological variables like lipid levels, etc. Those are the least susceptible to the placebo response in a clinical trial. Additionally, dichotomous variables versus continuous variables make a big difference. Something that's continuous is more likely to have a placebo response in a clinical trial than, say, dichotomous outcomes, yes or no, or threshold effects in measurement. So when we talk about the physical placebo or the invasiveness of a placebo, we notice that the more dramatic the intervention, and surgery is certainly one of the most dramatic or invasive medical procedures that we have,